Hello, and welcome to the first episode in a series of podcasts in clinical surgery. My name is Rashmi Patel, and in this podcast, I'm going to cover disorders of the peripheral vascular system which affect the arterial supply to the lower limb. The commonest cause of disease affecting arteries which supply the lower limbs is atherosclerosis. This results in a plaque in the wall of an artery which can directly obstruct blood flow. In addition, an atherosclerotic plaque can rupture, resulting in thrombus formation which may embolize to occlude more distal vessels. Both these processes can result in ischemia of the affected tissues, which can lead to infarction. Patients with peripheral artery disease usually present with intermittent leg pain on walking, which is relieved by rest, otherwise known as intermittent claudication. There are several important points to consider in the history and examination when assessing patients with intermittent leg pain. In the history, it's important to characterize the nature of the leg pain. Intermittent claudication usually results in a pain described by patients as cramping or tight in nature, and it may affect the calves, buttocks, or thighs, depending on which part of the artery is affected. Intermittent claudication may be confused with other causes of leg pain, such as sciatica, in which the patient often experiences pain on leaning forward or standing up from a sitting position, as well as spinal stenosis, caused by narrowing of the spinal canal, compressing the nerves in the cauda equina, and this results in pain which is usually worse on spine extension. The key with intermittent claudication is the pain is usually relieved on standing still for a few minutes, whereas with sciatica, spinal stenosis, the pain is usually only relieved after the patient has sat down. Having established a history of leg pain which is consistent with intermittent claudication, it is useful to know how far the patient can walk before they experience pain in their legs. This is otherwise known as the claudication distance. It's also important to establish whether the patient experiences pain at rest or pain at night, as this may indicate critical ischemia affecting the legs. In addition to pain, the patient may present with other symptoms in the legs, such as numbness or weakness, or the presence of ulcers. Having taken a history of the leg pain, the patient should be asked about risk factors for atherosclerotic disease. These include smoking, hypertension, hypercholesterolemia, diabetes, and a family history of any form of vascular disease. In addition, the patient should be asked about other lifestyle factors such as diet and exercise. Finally, the patient should be asked about the effect of their symptoms on their lifestyle, and particularly their occupation if they are working. This is because the level of disability caused by the symptoms will have an impact on the choice of management. Moving on to examination, on inspection, the legs may look pale and there may be loss of hair and brittle nails. The patient may also have arteriopathic ulcers, which are typically punched out, well-circumscribed ulcers present over bony landmarks in areas of poor blood supply, and they tend to be quite painful. In severe disease, there may be necrotic tissue, and in the presence of colonizing bacteria, this may result in gangrene. On palpation, the temperature may be reduced, and there may be a prolonged capillary refill time, as well as impalpable foot pulses. It may be helpful to perform Berger's test. This involves raising the legs up and looking for signs of a poor arterial supply, such as pallor and venous guttering. The legs are then allowed to hang over the edge of the bed and are observed to look for a reactive hyperemia indicated by a dusky crimson color and this also indicates a poor arterial supply. The time taken before the reactive hyperemia occurs may also indicate the level of severity of disease. Finally, an ankle brachial pressure index measurement should be taken using a Doppler probe. The normal value for the ABPI is usually above 0.9, and anything below 0.5 indicates critical ischemia. It's important to note that you may get a falsely high reading in patients who are diabetic, as such patients may have calcified arteries which are difficult to compress and so produce falsely high blood pressure readings when taking the ABPI. In addition, severe atherosclerotic disease in the arms may also provide a false reading. In terms of investigations, as well as general investigations such as a full blood count, fasting glucose and lipids, ESR-CRP, an ECG should be taken to look for atrial fibrillation, which could result in emboli being thrown off into the peripheral arterial system, as well as specific investigations to assess the level of severity of disease in the peripheral arteries. These include Doppler ultrasound, as used to measure the ABPI. A normal waveform on Doppler ultrasound is biphasic, but in an abnormal artery it may be monophasic. In addition, arteriography may be used to image the affected arteries in order to assess the level of stenosis. The importance of conservative management in patients with peripheral arterial disease should never be underestimated, particularly in reducing risk factors. This may include smoking cessation, control of blood pressure if hypertensive, and blood glucose control in patients who are diabetic. In addition, advice about diet and exercise can also help in terms of weight loss in patients who are overweight. In terms of medical therapy, the patient can be put on aspirin to help prevent an ischemic event, as well as being put on a statin to control blood cholesterol. Beta blockers should be avoided in patients with peripheral artery disease if possible, as they can cause vasoconstriction, which can further increase the level of ischemia to affected tissues. If the patient continues to experience disabling symptoms, then endovascular intervention may be an option. This may include angioplasty, which involves inflating a balloon within the lumen of the artery at the level of stenosis in order to improve blood flow. At the same time, a stent may be deployed in order to help maintain the lumen after angioplasty. If this fails, then bypass surgery may be an option. This involves using a graft to bypass the affected area of the artery in order to provide an alternate route for blood flow. The bypass may be made using a reversed vein, the vein being reversed to prevent blockage of blood flow by the valves, or by using a synthetic graft. If bypass surgery fails to control the symptoms, or the patient has gangrene which is life-threatening, an amputation of the affected limb might be necessary. So to summarize, in this podcast I have discussed peripheral artery disease affecting the lower limbs caused by atherosclerosis, particularly focusing on the important points in the history and examination, which include establishing the nature of the pain as being an intermittent pain on walking which is relieved by rest, and the importance of asking about risk factors in the history, and on examination the particular features which indicate ischemia caused by a poor arterial supply to the limb, and appropriate investigations which include general investigations such as bloods, ECG, as well as more specific investigations to assess the level of severity of disease in the arteries. And these include doing an ABPI as well as imaging the arteries using arteriography. I've also considered the management options, which include conservative management to reduce risk factors, medical management, which may include prescribing aspirin and statins, and interventional options, including angioplasty and stenting, as well as bypass surgery, and in severe cases or if there is life-threatening gangrene, amputation. So this concludes my podcast on peripheral arterial disease. Thank you for listening.